Hello and welcome to Doc Talk Live. This is NorthBay Healthcare's way of reaching out to the community on important health information. And with us today is Dr. Cornelis Elmes. He's an orthopedic specialist at NorthBay, and we're talking about the SI joint.
Right.
So welcome.
Thank you very much. Excited to be here, and thank all of you for tuning in. I hope this is informative and eye-opening. Because the SI joint is an important but often underappreciated and unknown cause of low back pain. In fact, I kind of think of it as the great masquerader. It can, and we'll talk about what is the SI joint later for sure. We'll hit on that. We'll touch on how you treat it, how you diagnose it. But in short, it's been missed traditionally because it kind of falls through specialties. It's an unusual joint, it's a small joint, it doesn't do a whole lot normally, but when it's painful, it can be a big problem. To be honest, it falls through the cracks of training. Primary care providers traditionally haven't been taught much in the way of orthopedics in general, let alone the SI joint. Orthopedic surgeons, it hasn't been part of the education for orthopedic surgeons, and spine surgeons, it's not really an area that they've previously addressed either. So I can tell you that when I was in training, which is a little while ago now, we weren't taught anything about the SI joint, and I only became familiar with SI joint problems as a trauma subspecialist, where I started treating people with SI joint injuries, and some of them didn't get better and ended up having chronic pain in the SI joint. And so I learned more about it and the way to treat it, and have now been operating on it with success. So I thought it would be helpful to put together this little talk to educate all of you on the SI joint because not many people know about it. So what I'd like to do is first I'll tell you a little bit about myself briefly, and then we'll talk about the problem. I'll show you exactly where the SI joint is in the body. We'll talk about how we diagnose it because it can look like a hip problem, it can look like a back problem. So how do you nail down the SI joint? We'll talk a little bit about that, and then we'll talk about treatment options. But first, a little bit about me. I've been here in California for 12 years now. I grew up in the Midwest. I studied both on the East Coast and the Midwest, did my training on the East Coast, and came out here about 12 years ago, and I've been here at NorthBay for over a decade. I'm an orthopedic surgeon. I have fellowship training in trauma, which is a lot of what I do, including fixing complex pelvic injuries, and that's how I became familiar with SI joint problems. I come from a family of physicians, not my parents, but I grew up interested in medicine because I have relatives who were doctors. I have an uncle who was an orthopedic surgeon, and so I had an interest in medicine to begin with. I ended up in orthopedic surgery because, as far as hobbies go, I grew up enjoying many summers with my dad fixing our cottage in Wisconsin. And we did everything from plumbing to carpentry, laying down new floors, and I loved it. We did model ships together. So I have a lot of fond memories using my hands to fix things and to build things. So when I went through medical school, interested in medicine, and I started talking to my uncle, who's an orthopedic surgeon, about what orthopedic surgeons do and how they fix things, that just seemed brilliant. It seemed perfect, and it has been a dream, career for me to be able to do what I enjoy in the context of working and helping people. And so that's how I ended up here. Otherwise, fun facts, hobbies. I'm a big racing fan, car racing fan, and I enjoy performance driving my own car on the track whenever I get the opportunity, which isn't too often, but I enjoy that. Happily married, have 2 great little Labradors, and I live here in Fairfield. So enough about me. Onto the show. So the SI joint. It's common. It's way more common than I think any of you would believe it to be. Low back pain is actually the number 2 reason why people go to the doctor to begin with, of all reasons. Number 1 being the common cold. So prevalence of back pain is large. 90% of people are going to have a problem with their back at some point or another. Of those who go to the doctor to be evaluated for chronic low back pain, actually 15 to 30%, depending on the study, suggests that 15 to 30% of people who present with chronic low back pain, it's actually their SI joint and not their back at all. Plus, you got a whole bunch, and that's just the low back pain people. I see a lot of patients with hip problems, so hip tendonitis, hip bursitis, and some of them actually, yeah, they have the hip bursitis and tendonitis, but they have that because they're actually having SI joint as the main problem, and they're developing these other conditions around that because they're chronically in pain. So it's pretty common. It's particularly common in people who have had lumbar surgery. So many people have been evaluated by a neurosurgeon, had a lumbar fusion, and for some reason they're still having pain. Previously, it was thought that these patients just, failed the surgery, basically what they call it, failed back syndrome, or they started getting arthritis at levels higher or lower from what they had fused, say, when they had fusion. Now, as people are becoming more aware, we're learning that it may not be the spine at all. They may have developed now problems in their SI joint, or maybe they had problems in their SI joint all along. It's funny, I actually had a spine surgeon colleague joke with me that when he was in training, he was taught that there was no such thing as an SI joint problem. They said the SI joint isn't really a joint, it doesn't do anything, it doesn't move much, so how can it be a problem? And they really discounted it as a problem. Fortunately, it's been pretty well proven that that's not the case. It is a joint, and yes, it doesn't move very much, but it moves enough that if it becomes painful, it can become a problem for people. So it's common. As I mentioned before, it can often be confused with hip problems, low back problems. The impact on society is significant, right? SI joint arthritis or pain can be as disabling as, say, bad knee arthritis, hip arthritis, or back arthritis. Those problems, of course, as you know, are often treated with surgery and effectively. And fortunately, the SI joint can also be treated now effectively with surgical options. So, onto where is this SI joint? I've been getting you all excited, leading you up to it. I'm sure you're all wondering, where is this mysterious joint? So I brought some models with me to show you. This is one of the models I use sometimes for trauma. So it's got all kinds of markings of where I draw fractures and plan my fixation. So please ignore that. But it's the best model I have to show the pelvis. The SI joint connects your spine to the lower half of your body, basically. So it's an important little joint. Your spine comes down here, ends on the sacrum, and the SI joint is what connects your sacrum to your ilium bones. So SI is short for sacroiliac. This is your iliac bone. This is your sacrum. SI joint is a sacroiliac joint, which connects the two. It's important because it's essentially a shock absorber from impacts on your lower extremities to your spine. So when you're running, lifting something heavy, for example, it diffuses some of the forces to your spine to decrease your risk of having a back injury. There isn't a lot of motion there. Normally there's about 2 millimeters to 4 millimeters of translation, rotation, and sort of sliding back and forth and also rotating around the axis here. That's not a lot. If you injure it, you can actually have quite a bit more motion there. A little bit of motion, like in all of our joints, is healthy and comfortable. However, if something happens as we get older, like an injury, or you get some sort of inflammatory arthritis, just like your knees or your hips, it can become arthritic, it can become painful, and become a problem. So I have another model here, which we're also going to come to later, because it actually shows how I fix these. But it's a good model because it shows you what the joint looks like. If I were to remove this bone right here and show you the side of the joint, actually this is already coming apart. The joint's right here. It's hockey-shaped, stick-shaped, kind of boomerang-shaped right here. It's pretty small. Let me put that back. Yeah, that's it. So it's actually part of your pelvis. So the most movement that we see in the SI joint is during pregnancy. And that's because the maternal hormones that sort of, they relax all the ligaments in a woman's body to help with childbirth. and that relaxes the ligaments. There are all kinds of ligaments and muscles that attach to the pelvis around the SI joint to stabilize it. Those all get soft in pregnancy. They loosen so that the pelvis can actually open up a little bit if necessary for childbirth. So it's not uncommon for pregnant women before and after delivery to have pain in the low back. Part of it's because of strain in low back because of the added weight on the, at the belly in front of the body. But it can also be the SI joint becoming a little bit lax and seeing higher than usual stresses on it. That usually resolves after childbirth, but it's not uncommon. So you can have SI joint problems in young people as well, particularly young women who have had children. Sometimes those ligaments get stretched out sort of beyond their elasticity to kind of come back to normal after childbirth, and they could be just like if you sprain your ankle too many times, that can become painful chronically. The same can happen to the pelvis. The ligaments can get stretched out and they never quite go back to normal, and then you have too much motion at that joint. They become arthritic and actually become painful. So young people can get this problem. Childbirth is one, trauma is another. You could go skiing and fall hard on your butt or on your side. And that could be enough to sort of either loosen the ligaments and cause pain or start an arthritic process that causes a chronic problem. Car crashes, motorcycle crashes, anything that you could think of that involves a high impact to your pelvis can cause a problem. And pretty much anything that could cause back pain, if you think about it, could also cause problems in the SI joint.
Can heavy lifting be a problem with?
It can, and it could be one of these things like, unfortunately, as we all get older, you can do a lot when you're young and fit, and then as you get older, you can suddenly do something that you once used to be able to do without a problem, and it can cause a permanent injury, right? Just like the back. Part of that's because maybe our ligaments aren't as strong. We know that they lose some of their strength as we get older, but also a lot has to do with core strengthening. We'll get to that later as a treatment. But just like with back problems, it's so important that our abdomen be strong. And when we're kids, we're running around like little animals, just jumping around, climbing trees. They're strong, they're fit. Kids are fit, right? And you go through high school, and maybe you're an athlete. You go through college. When you're younger, your core is strong, and that supports your spine, your SI joint. As we get older and we start working, and we're not as athletic, we lose some of that core strengthening. So if you go to the doctor, if you've ever been evaluated for back pain, that's one of the things they're going to tell you right away. Let's get you into physical therapy. Let's get you into core strengthening with physical therapy, and that does help. But to your question, yeah, absolutely. We get a little bit older. We're not in the gym all the time. We've got busy lives. Now we pick something up heavy. We don't have the core to stabilize the spine and the SI joint and the pelvis, and we can sustain an injury. Yeah. Mm-hmm. So let's talk next about symptoms. So, what does it feel like when you have an SI joint problem? The pain can vary. It can be sort of an aching pain. It can be a sharp pain. It can be a radiating pain. When I say radiating, it means it can start sort of the low back area and kind of go down a leg. That's why it can mimic sciatica. If any of you have sciatica, it can feel like a burning, shooting pain. You can get numbness and tingling, which is a little odd, right? Because we're not really pinching a nerve like you would in a back problem, but it's not uncommon to feel numbness and a tingling sensation going down the back of your leg. More often than not, it ends at the knee, and the typical pattern is sort of posterior thigh down to the knee and it stops. But in 25% of people with SI joint problems, they actually get that symptom radiating all the way down to their foot. So this is why it can be confused with sciatica, because sciatica can present with very similar findings. And the reason for that is the nerves that innervate this joint are very close to the nerves that also go down to your foot. They're sacral nerve roots. You get some crossover feedback to your brain, and it just, the nerves aren't good enough to really differentiate those areas. Similarly, the hip gets similar innervation. So someone who, it may feel like a hip bursitis. You may feel pain or tenderness in your buttock area. It commonly is painful to sit, for example, and that's because if you go back to the model, you sit on these bones right here, the ischium. Okay, you sit like that. So if you've got an arthritic joint back here, when you sit, it's putting stress on that joint. All the weight of your upper body's coming down, your butt is here supporting it, and you've got a force that's going like that as you sit. So sitting is painful, and you'll feel an achiness sort of off to the side in the low back region. People with really bad pain, you'll find that they kind of sit like this to take pressure. If it's the left side that's hurting, they kind of take pressure off it like that. People with really bad SI joint pain, they fidget a lot. They're standing up, sitting down. They can't sit still. Standing hurts because when you stand, you put weight on that leg, and your body, the whole weight of your upper body is coming down again, down to here, and your leg is here. And so every time there's pressure on that side of your body, on that limb, you're feeling pain. So people will have to shift their weight when they're standing a lot. They often sit down for 5 minutes, 10 minutes, and have to sit up or stand up when it's really severe. Similarly, lying in bed, if it's your left side that's hurting, when you sleep on your left side, you're putting pressure on that joint. So it's really unfortunate. It's a really bad problem because it's hard to get comfortable. It disrupts your sleep. You end up rolling around a lot, and when you do roll, it hurts. To alleviate the pain, you end up sleeping on your other side. You end up shifting your weight. A couple other things you can do. Like I mentioned before, core strengthening. If you're a little heavy, you can make yourself lighter. That helps. And there are SI joint belts, which are kind of like lumbar corsets, that you might wear for a low back problem, but you wear it lower around the hips. So if you can picture that, a strap going around the hips just kind of squeezes the SI joints together and stabilizes them, which decreases motion and decreases some pain.
I have a question.
Yeah.
You said it can mimic some other problems. So how do you diagnose it? What are you doing as a doctor to figure out that it's SI joints?
Perfect. Great segue. So diagnoses. The first thing we do is we do a thorough physical exam. You want to do a good hip exam to rule out other causes of pain in that area, such as hip arthritis, bursitis, tendinitis around the hip area. And then, of course, you want to do a basic back exam to see if actually you've got back arthritis. And then lastly, there are specific physical exam maneuvers that can be done to sort of elicit SI joint pain. So we go through all that. It's actually a pretty, it's one of the longer workups because you do have to cover all those parts of the body, and getting a thorough history is important too. But if you find after all that someone does have symptoms and history consistent with possible SI joint problem, I like to send patients for a diagnostic test, an injection test. I send my patients to an interventional radiologist who basically sticks a needle under sedation, if you like, so it's not anxiety provoking, but you stick a needle into that joint and you inject a little bit of local anesthetic in there, and if it takes away the pain, even for an hour or two, that confirms the diagnosis. So I think that's a great way to test. It's not foolproof, but when you combine the physical examination, the injection test, and a good response to that, then it's highly correlated with an SI joint problem.
Okay. We have a couple questions being posted, and just as a reminder to those who are viewing, if you have a question, just type it in the comment. We'll be able to see it and pass it along to the doctor. So Rick is asking, does pain from the SI joint radiate through the hip?
Yeah, it does. It's typically, if we look at the back here, it kind of often starts here. Like if you were to ask a patient to point to the part that hurts, they're pointing off sort of in that dimple. If you know the dimple on the back, low back by your buttock, there's often a little dimple, especially noticeable in skinny people. It usually starts there and it's sore. It might even be sore to touch. But then you get this radiating effect where it kind of comes down around the hip area. You might feel it in the groin, but it kind of wraps around the buttock, down the thigh, either in the back part of the thigh or the side part of the thigh, and maybe even down to the knee. Now that's not always the case. It can feel just like hip pain, low back pain and hip pain. There are even some people who don't describe it as low back pain at all. They really describe it more as sort of buttock pain and hip pain. So again, that's why the physical exam is so important.
Okay. And Sharon is asking, can an extra vertebrae put pressure on the SI joint? Didn't know you could have an extra vertebrae.
Yeah, you can. Yeah. You can have a hemivertebrae. So, yes. The question was, can an extra vertebrae create this problem? And that's a good question. When you say extra vertebrae, you might be referring to a hemivertebrae or something like that, where you have like a half a vertebrae, some sort of malformation or abnormal formation of a vertebral body. Without being a spine surgeon, what I can say is anything that can sort of cause your pelvis to tip, which an abnormal vertebrae shape might do, can cause problems in the SI joint. If your limbs are unequal length, all of us have uneven limbs. If you measure them out, like whether it's a few millimeters or even a centimeter, one leg may be longer than the other. And if that throws off the pelvis alignment, you can get problems. You can also get arthritis sort of at the base of the spine towards the sacrum here, which can cause pain. And that's a tricky one. That can be confused with SI joint pain. It's not really the SI joint, though. That's more of a back problem. I hope that answers your question.
Okay. What percent of people can get relief from an SI joint fusion, which we haven't touched on yet, but maybe explain what that is.
Okay. All right, well, that's a good segue, as I say, as well. We're getting to the treatments. Let me rewind for 1 second and just say the treatments. There are some non-operative treatments, and then we'll go talk about the surgery that we do here at NorthBay. Non-op treatments, physical therapy, right? That SI belt that we talked about. When you get that injection, you can actually get steroid included. I don't know if any of you guys have had steroid injections for knee joints, hips, whatnot, but you can get it injected there, just like for the spine. That provides relief. Better for someone who's having like a flare-up. It's kind of a one-time thing. They lifted something heavy, like you were saying, and it might, it's not a chronic condition. Then a steroid injection might help. However, the effects of the steroid it does wear off. It only lasts about 3 to 6 months. So if it's a chronic condition, a steroid injection is not going to give you long-lasting permanent relief. It's more of a temporary fix. There is something called a radio frequency ablation, or RFA for short. That's something that pain management specialists can do, or anesthesiologists. That's another sort of more short-term fix. Essentially what they do is they go in with a device to sort of numb basically deaden the nerve endings that innervate the joint. And that, again, has only been shown to work for about 6 months. So I usually don't recommend that, because if you have a chronic condition, it's a short-term fix, so why bother with that when there's a more definitive surgery out there to solve the problem? Which gets to the fusion, which I'd like to talk to you about today, because we've had great success here at NorthBay treating that with fusions. I use an implant called iFuse by a company called SI Bone. This implant's been around longer than all the other ones out there. If you Google SI joint fusions, the iFuse implant's been around for, I think, 11 years. It by far has the longest track record. It has the most research behind it. It's got the best research of prospective randomized trials. And that's why I decided to use that implant. And the results are very good. Greater than 90% of people who have had the surgery are glad they had the surgery and would do it again, which I think says a lot. It doesn't necessarily get rid of 100% of the pain, but it is significant. I can tell you in my experience, I've had people with debilitating pain for years. They have this surgery done and their pain is gone. And it's often gone at 6 weeks. So it's pretty dramatic. And the studies show that this surgery is very successful even in the long term. The data goes out 5 years, which for this sort of thing is pretty long. And considering the implant hasn't been around for very long, that's all we can really hope for right now. I hope in another 10 years we'll have even longer data on this. But I think if you're going 5 years, with my experience as a trauma surgeon, 5 years is a long time. If you're doing well at 5 years, I don't think things are going to change going forward. So, if you're feeling really good at 3 months, you're probably going to continue to feel good, for a long time, if not, for the rest of your life, I hope.
So what are you doing in the fusion? Like, what are you fusing and how are you doing?
Yeah, okay.
For us lay people.
Well, yeah, so, SI fusions have been done before. Again, it wasn't common because it wasn't part of most orthopedic surgeons or spine surgeons training. But the old school way of doing it is an incision on the back area, like a big spine surgery. You open up the joint, You scrape out the cartilage without getting too gory. You put bone graft in there and a screws or some sort of construct to squeeze it together and get the whole joint to fuse. So a fusion is when you get rid of the cartilage and you get bone to grow across that space. So you get bone from the ilium and sacrum growing across what used to be the joint. And once that's solid bone, pain's gone. There's no more joint, right? So you don't have arthritis anymore. So it just becomes one solid mass, right? So big surgery, bigger recovery, higher risks because it's a big open surgery, risks of infection and things like that. So it wasn't commonly done. What's nice is, with the iFuse implant, it's a minimally invasive surgery. It's outpatient. The incision is much smaller. It's about 2 inches. Surgery takes about an hour and a half. This model, probably not the easiest to see. I can bring it into the camera a little bit.
I'll zoom in a little bit here.
But this shows schematically what it looks like. Typically, I use 3 implants. Sometimes I use more. I'll pull one out so you can see what it looks like. Well, here we go. They're triangular shaped. They have sort of a cylinder shape to them. I got this out earlier.
Well, it came out earlier.
It did. Well,
it's fused.
It's fused. Here we go.
Here we go.
So it kind of has this, almost a bullet shape to it, right? But it's triangular. It's about that long. And it goes in through incision about that big, sort of on your buttock. So it's very discreet. No one's going to see it. And you basically just make a small incision enough to pass these implants in. 3 of them go in generally in a sort of an array like that. And they go across the joint, right, like that. And essentially the goal is to spot weld. These have sort of a porous coating on them, which are little pits that bone can grow into. So the goal is to get bone to grow into the implants on each side of the joint. And if that grows in solid and that grows in solid, then the joint stops moving. Now, it's not a complete fusion in the traditional sense where you're really trying to get bony fusion across the entire joint. Rather, what we're doing is we're hoping to spot weld. The advantage being outpatient surgery, almost no blood loss, pain and recovery, everything's much easier, minimally invasive. So it has a lot of those advantages to it. But it's not a complete fusion in the sense of going in there, opening up the whole joint and literally getting rid of it and fusing it. That is probably the bailout, say if this doesn't work, because about 8% of people don't get the kind of results that they were hoping for, or I'm hoping for, right? And that would be the bailout surgery, is to do a more open surgery to get it all to heal. But this minimally invasive approach, that's how that works. You're basically spot welding the joint.
Does the surgery limit flexibility and mobility?
Excellent question. Unlike spine surgery, where you lose motion in that disc space, right, which is already losing motion if you're arthritic, right? But yeah, once you fuse it, you lose all of it. Or if you fuse a different kind of joint in your body, you lose all your motion, right? Going back to the point that the SI joint is not supposed to move very much, right? 2 degrees, 4 degrees, it's not much. So that's another nice thing about this surgery is, no, you're not losing motion because there isn't supposed to be a whole lot of motion there. It's almost like the joint has just enough motion to be a problem, but it doesn't really help you that much. It acts as a shock absorber like we talked about, which is important in running and things like that. But in terms of losing motion, no, you don't lose motion. That's the whole goal of it is to get rid of all that motion, but you don't lose any motion in terms of how your back or your hip works.
Leslie's asking, if it didn't work, would that leave me with more pain?
I haven't seen that, and I don't think so. Usually what happens is the pain, people who get this surgery are in usually quite a bit of pain to begin with. So it doesn't, usually what happens is it doesn't make the pain better. And that in about 8% of people, that's the case. And our experience here at NorthBay is in line with the published literature, where 90% of people have a significant benefit, so significant that maybe it's not 100% relief, though I have seen that happen quite often. It's so dramatic that it's worth it, and they would do it again in a heartbeat, because now they're back to work, they're working out again, their life's so much improved. When it doesn't work, and I've seen that happen in a couple patients, they just don't get better. They don't see the kind of results. They feel like they still have pain. And then, of course, if that happens, the follow-up surgery would be something more traditional, where you would, either revise it, where you put maybe a couple more implants in to make the whole thing even stiffer, and limit the weight bearing, the recovery period a little bit longer, or you go back to a more traditional approach and really just, get it diffused by getting rid of all the cartilage. That's literally what you do, putting bone graft in there and then fixing it with screws in a more traditional manner.
Okay. Can removal of the, I don't know if I'm going to say this right, piriformis muscle on one side cause SI joint pain on the opposite? Pardon me if I pronounced anything
No,
wrong.
very good, very good. And pardon me for not saying the question again. The question is, if you had your piriformis tendon released for some reason on the other hip, can it cause SI joint problems on the other side? I don't know the answer to that. I'm trying to think that anatomically through. I don't think so, but yeah, I can't see how that would be. But I can tell you that any sort of abnormality to your gait, could potentially cause symptoms there.
Okay. Are there exercises or other procedures that can be done from an old injury to the SI joint?
Yeah, I mean, any core strengthening is sort of the mainstay, which sounds like it's not really addressing the problem, but it is. We also send our patients to physical therapists, specially trained in pelvic floor therapy, to strengthen those muscles, of the pelvis. But it's equally as important to focus on the core. If you can strengthen and condition all the muscles of your abdomen, your low back, and the pelvis, that may stabilize the pelvis enough to alleviate symptoms.
Okay. Is it possible to tear the SI joint? We hear about people tearing their kneecap or whatever.
Absolutely. When I mentioned traumas like falling, you can tear. So by tearing the SI joint, what you're referring to is the ligaments that hold the joint together, right? We have ligaments around all of our joints, and they're essential to keeping it together. You can tear them just like any other joint. The most severe cases are pelvic injuries, like motorcycle crashes, for example. The whole pelvis can open up. We call it an open book pelvic fracture, and all those ligaments get torn up the front. That's the most dramatic example that I see. But certainly there are far less injuries that can cause, essentially sprains of those ligaments. And if they don't heal right, that can result in a chronic problem, yeah. And that can happen just by falling on your butt or falling on your side.
When you showed your example, you showed the fusion on one side with the little triangle things. Can you have SI problems on both sides at the same time, or is it usually one side or the other?
Yeah, definitely. That's really common, actually, to have it on both sides. So if it's an injury, it might just be an isolated one-side thing, right? But some people just get SI joint arthritis because they're getting arthritis for whatever reason, whether it's genetic or you're getting arthritis in multiple joints as you're getting older. You can get them in your SI joints, and in those people, it's often bilateral. So we do bilateral, fusions. It's not uncommon. I don't like doing them both at the same time because I do limit weight bearing for a brief period of time after the surgery to wait for the bone to heal into the implants, which is really important. So I don't do them both at the same time because how can you keep weight off of one leg? That's what I ask people to do, is to keep weight off one leg. But if you do both sides, you can't favor one leg over the other, right? So you're bedridden. So I don't do that. There may be people out there who do, but it's not recommended. I think it's important to limit weight bearing on that side after surgery until the bone heals into the implant. Because if it doesn't, then that's what causes failures, is if the bone doesn't actually integrate into the implant. But I can tell you that, I fixed one side, people feel great, and then they want their other side done. Some people choose not to get the other side done because they feel so much better having the one side done that they start doing these activities again and they want to see how it goes. I think that's fine. But some of them certainly want the other side done right away, for those more severe cases.
Right. Does this affect more men or women, or is it about equal?
I don't have the answer to that. I can tell you that the women have more motion in their SI joint. They also have the issue with pregnancy and the ligaments getting lax. So I think theoretically the incidence might be higher, but I'm unaware of any data that specifically looked at that.
All right, Laura's asking, if the pain has been chronic for a long period of time, can the surrounding muscles become contracted and weak, contributing to the pain down the leg, affecting the is that IT? I can't read your writing. IT band, as well as the anterior quad. Can you even have leg shortening due to the pulling?
Okay, there's a lot to unpack.
That was a long question.
Of that question. What was the original injury or problem?
She just said if the pain has been chronic for a long period of time, can the surrounding muscles become contracted or weak, contributing to the pain down the leg and affecting the IT band?
Okay. IT band, that's a problem in it of itself. That requires its own sort of stretching exercise. That kind of falls under the category of tendinitis and hip bursitis, which is common with SI joint problems. So I don't think we have a reason for that specifically, but I do see it associated with SI joint problems quite a bit. I speculate that when someone has chronic pain like that, it disrupts your gait. It changes the way that you walk. And when that happens, that's a setup for having hip tendinitis, hip bursitis. You mentioned the IT band. That's usually associated with hip bursitis. So I think if you have chronic SI joint pain, if it's impacting your mobility, if it's impacting your level of fitness, if it's impacting the way in which you walk, then certainly that can exacerbate those hip problems that you mentioned. Similarly, if you have hip problems, that could cause a worsening of symptoms in the SI joint, because again, anything that changes the way you walk can also change the dynamics across that SI joint that's not supposed to move much but does move.
If you know that you have one leg that's over a quarter inch shorter than the other, are you doomed to have SI joint issues later in life?
No, I don't think we can predict these things. Most of us don't have even limb lengths. We do know that you say a quarter of an inch. That's roughly a centimeter. We do know that people tolerate a centimeter of limb length discrepancy generally fine. Once it's more than a centimeter, people may begin to have issues, whether it's knee or hip or ankle, back. They could have issues, and that's pretty easily addressed with a shoe insert to kind of even yourself out. But again, we all have our own sort of risk factors for arthritis, and SI joints, like every other kind of arthritis. Can that be something that sort of pushes you over the limit into a problem with your SI joint? I suppose it could, and that's pretty low-hanging fruit, if you will. That's pretty easy to fix. If you know you have a limb length discrepancy, get a shoe lift of a centimeter, stick it in your shoe, and see if that alleviates your symptoms. That'd be an easy fix.
Okay. Do you see this condition in people who are relatively athletic with repetitive hip motion in their athletic activity?
I don't see those patients too much, and I wonder if they're just thinking that it's low back pain. I think a lot of athletes who have pain in that area, and the question, let me go back to the question again, it's, do I see this condition in athletes? And the answer is no. I certainly have patients who are athletic who have that problem. They're generally younger. I think a lot of these people are sort of managing the problem themselves by strengthening their core, and that can alleviate a lot of their symptoms. But I do see it in young people who are active, and they do feel it with high impact activities such as jogging and running.
Okay. So, what is there a lot of physical therapy after this procedure?
Well, okay. So when I see someone who has SI joint problems, that's one of the first things I recommend. Many of these patients get referred to me from neurosurgeons. Though I welcome referrals from primary care docs as well. But if they've gone to a neurosurgeon or a spine surgeon, they've often written for physical therapy because their conservative treatments are often similar, and they're getting these patients because primary care docs are unaware of the diagnosis. They're calling it low back pain, and they're sending it to a spine surgeon. So the time that I get referrals for SI joint from primary care is when they think it's more hip pain. And unfortunately, there's greater awareness of the diagnosis, and I'm getting some referrals now on primary care docs who are acknowledging this as SI joint pain, but usually they're not aware, and it's either hip pain or back pain. So that being said, if they do go to a spine surgeon, they're often getting referred to physical therapy to strengthen their core. And that does help the SI joint problem. So if that hasn't been tried yet, and someone comes in with SI joint problems, that is one of the first things that I do is I prescribe physical therapy and maybe an SI belt to see if those measures help. And it's when that no longer helps that we start talking about surgery. Physical therapy is never wasted. We usually try it for about 6 weeks. If it doesn't help cure the problem, it certainly sets you off on the right trajectory, to having the surgery and having a good outcome. Because again, most of us lose our core strength as we get older. Throw in some pain that keeps you from working out, you're going to lose your strength even more. So it's a good place to start, even if it doesn't work. Because after surgery, I do write for physical therapy then as well to help in the recovery period. Once the fusion surgery has been done, there isn't too much more. The only thing that I'm asking, or that I ask patients to do after surgery, is to not put weight on that side for a period of 3 to 6 weeks, depending on bone quality. And once that's done and passed, then I don't really restrict patients much anymore. I usually encourage them not to go running or high impact activities for the first year or so. Just do things that you can be athletic, but avoid the high impact stuff. So cycling is fine. Skiing, probably not a good idea because if you fall, you might whack your pelvis. Those types of things. At 1 year, I release all restrictions. But physical therapy, I usually recommend post-op. It's not necessary. Some people choose not to do it. But I think, once your pain starts feeling better, it's a great opportunity to start paying attention now again to the core again, and those pelvic muscles. So I think it's helpful. I think it expedites your return, to normal function, post-op.
We're almost out of time here, but you've done several of these surgeries. Like, what kind of outcomes you seeing?
Yeah, we've done many of these at NorthBay, and as I mentioned before, fortunately, I'm proud to say that our outcomes are similar to the published literature, which is, greater than 9 out of 10 people, so, literature about 92%, are very happy with their outcomes and would do it again, which I think speaks, volumes. So pretty high success rate. And, okay, I guess we're running out of time.
You're going to
yes.
visit our website.
Thank you for participating in this Doc Talk today. I hope everyone out there learned something, and maybe it's helpful information. If you think that you might have SI joint pain and want to be evaluated, the easiest way to do that would be to go to our website, northbay.org. There's a search engine there.
You go
It's even simpler.
SI.
Yeah, you can do /SI bone, or just go to northbay.org, put in the search engine SI joint, and the next page will show up. Like the first thing that comes up is SI joint pain. You just click on that. It's the first link, and they'll have a whole page on there talking about SI joint pain. There's a little quiz on the side that you can take. That's actually put up by the company that does the implants. You can take that quiz, and it'll tell you whether or not there's a good chance that you might have an SI joint problem. And if you do, then come see me. And the next step would be to do a good, thorough history and physical exam and see if you do. You can make an appointment at 707-646-5599. Again, that's 707-646-5599. That's here in Fairfield.
Great. Thank you so much, Dr. Elmes. For those who are viewing, we have a chat tomorrow at 6 p.m. on open enrollment. So if you have questions about open enrollment, join us here at 6 p.m. And then on Thursday, Dr. Neil Patari will be talking about knee pain. So thank you all for tuning in, and thank you, Dr. Elmes.
Thank you.